Hi, everybody. It's Anna here from Osteo Kids Academy. Today I'm with Cindy de Nooijer, who is a Netherlands-based osteopath with a special interest in the care of babies, children, and pregnant women. She studied at the International Academy of Osteopathy in Ghent, Belgium, and then completed a master's in osteopathy from FHG Innsbruck in Austria. Cindy has an interest on the influence of birth positions on babies' bodies and uses facial cues and body language to help guide her assessments. She's particularly skilled as well in addressing breastfeeding issues. In addition to her clinical work, Cindy teaches paediatric osteopathy courses at Panta Rei, which is a Greek phrase meaning everything flows or all things are in flux. Cindy is a lifelong learner and brings a wealth of experience and knowledge to us today. Welcome, Cindy.
Welcome. Thank you for the nice introduction and for the invite for the interview.
It's great to have you. So you're based in the Netherlands. Tell us about the osteopathic profession in the Netherlands.
Yeah. So osteopathy in the Netherlands is mainly known as alternative medicine, but I rather prefer complementary care because I think we're really able to work complementary and just as an addition to regular healthcare. We're not officially acknowledged by the governmental rules. That means that we don't have protection of our titles, and like everyone can say, I'm an osteopath. So that's a bit, tricky, but I don't have the idea that a lot of people are misusing the title. And although we are not officially recognized, the organization of the profession is kind of the same as in the physiotherapist in the Netherlands. So we also have a register, and you need to re-register every 5 years and get your CPD points, like 160 in 5 years. Most of the osteopaths in the Netherlands have primarily worked as physiotherapists. And after that, they did a part-time osteopathy study at a private institute. And that took about between 4 and 7 years. They changed the curricular programs over the years, and depending a bit on the school. There are schools where you only can get in with a medical degree on front, but there's also a school where you can start from being a secretary to just becoming an osteopath, but then it takes 7 years or something. Since this year, there started officially recognized school, which you can start after high school, and that's a 4-year. They just started, and it's waiting what the quality of the students there will be when they are finished. But it's one of the things that the organization in the Netherlands really wants, is to get acknowledging from the governmental rules. So they think they will get better repaid, because in the Netherlands, when we look at the healthcare system, osteopathy is not in the basic healthcare, but you can have an extra plan where they will refund the patient for 40 euros. And for example, my rate is around 90 euros. So they will get a small refund, but they hope it will get better. But they're definitely striving to get the acknowledgement. But I think, like it's in more countries nowadays, that there's a bit of partition between osteopaths, that one part really wants to acknowledgement, and the other ones are afraid that we will lose our identity because of all the work through evidence-based practice and the more traditional osteopathy. For me personally, I'm a real fighter for the original osteopathic philosophy, because I really like to read also the old books from the way still students. But I also know that research will be important to keep the osteopathic profession healthy. But I'm really for we cannot lose our soul with the principles of still.
Mm, yeah, interesting. That's that's really interesting because in Australia, something similar, sort of the discussion is similar, I would say. We're quite highly regulated here, and some would argue to the detriment of the profession in Australia as far as uh, the practice of osteopathy and where how far we go down the evidence-based path to become recognized and part of the medical field and what if anything we might lose walking down that path. It's a bit of a tricky one, isn't it?
Yeah, it's real tricky, and I'm really you see it in some other countries. For example, United Kingdom is already that they're a bit hesitated with visceral techniques, and before you know, I guess you're coming in the field of manual therapy, and I think we have a really good background, mainly in treating like the whole person. And
Mm,
and just treat what's necessary and not the kind of things so only fix small parts and then you really need to oversee the whole and I think that's gonna miss very fast when you're going to uh, the mainstream medicine and yeah, I think it's everywhere. It's like the partition and it's also yeah, nice to see where are we going, but yeah, I
yeah,
think there are a lot of publication also. Are we on the right path? And that's kind of stuff. But yeah, I'm really yeah hoping to be part of that. We can hold to our soul and just also do some evidence-based research. My colleague, um, the director of the organization Panterij. He just started a research group on osteopathy in the cranial field. So we're going to start with a colleague of 10, yeah, to look if we can do some research and we can give some proof for our techniques in the cranial field. So yeah, that's really nice. He's always busy and he's the one who asked me to teach once and put me just 3 weeks before if I can teach because another colleague was fallen out and he said, "Yeah, can you teach in 3 weeks in Norway?" And then I said, uh, "Okay, I think I need to I need to do that. I will do it." So
well
there was a
done.
presentation. There was a presentation, but I just 3 weeks. I only did make the presentation to my own way because it's always difficult to tell someone else's story. And I stood in Oslo for the first time, and it was really nice. And I'm always laughing a bit at myself because I always say, yeah, when you told my 20-year-old that I will be teaching in 20 years, I would say, yeah, you're crazy. I'm never going to teach, but I really like to teach. And yeah, the longer you do it, it's nice to give your knowledge to other colleagues and
Yeah.
just help them around. And the most important thing, and that's, I think it's also very incorporated in osteopathy, is that everyone um, develops on another way. Everyone has their own style, but you can learn for others, but just pick out what you think suits best for you.
Mm,
And that's what I also want to acknowledge and say to my students. So you don't need to be a copy of me or a copy of my colleague or whoever who is teaching here. Just become your own osteopath and pick from me and for my colleagues what your suits best.
mm. That's a really humble way to teach, I think.
Yeah, but I think that's it's nice to be a bit on the same level at our all colleagues who have already had their osteopathy diploma, so they just want to gain more experience in treating babies, children, and pregnant women. So yeah, you
Yeah.
can just take them by their hand and show them something, and
Right.
it's always nice to see how they develop during a 2-year course. That they grow in their confidence, and yeah, that they maybe we always have like a training day in the end of the year. So then there come a lot of patients. So sometimes we have 45 patients on a
Wow.
day,
Yeah,
because then we
wow.
have eight groups similar working, and then in the class, and they need to do the examination, the treatment with a group. And in the beginning, the first year, they're really, oh, I'm afraid and we can't, and I'm feeling seen, and you always see that there are people who stand up and take the lead. And after a year, you see that no one is holding himself back, but they're just treating with their together, and that's real nice to see that development.
Yeah, right. Oh, it sounds like you're a teacher through and through, Cindy.
Thank you. Yeah, I really like it.
Speaking of teaching, this is the bit where I'm going to pick your brains about being a pediatric osteopath. Um, one of the questions we have for you is when you see a baby that has certain musculoskeletal, a particular presentation, and they've had a certain type of birth, what do you look for? Like what sort of births do you notice linking in with certain musculoskeletal presentations?
Yeah. So yeah, in my teaching subject is the birth in the
Hmm.
pediatric program. When I'm teaching about it, students often ask for why do you need so much? Why do I need to know so much about birth? Because it's not my responsibility to deliver a baby. And by practicing, teaching, and studying the birth, I realized more and more that it's also important to give the baby acknowledgement for the way he or she have been born. And that's not always completely verbal or with your hands, but that can also be like in your mind. So I know you were stuck over there, or you had to wait a longer time because uh, there was no gynecologist, so your mother had to wait, and then you had it tough. So sometimes it's just in my mind to give the baby acknowledgement for the path he has.
Hey,
But always also sometimes I'm just verbal encouraging. For example, when the clavicle is very tight, I treat it, and then you sometimes get that the baby is started to cry. And yeah, there are a lot of types of crying for babies, but I recognized the cry, and then I said, oh yeah, it was your shoulder, and your shoulder was stuck. So yeah, that was very difficult. And then I say, oh, you gonna just tell it what you felt. And then you see that the baby relaxes and stops crying or cries for a bit. And I always tell the parents that's what happens. And
an
also
emotional release, sort of a
the
cry.
emotional release from the baby, and you help them to get further. And further, more easy things is that babies who have a left occiput anterior lie. So for the ones who don't know exactly, it's just that the baby is in the pelvic area of the mother, and the occiput is on the anterior side of the mother, and then left. It means that the right ear is in front. You see that babies mainly have a preferable position with the head to the right. When there's a preferable position and the lie was left occiput anterior, mainly the preference dominance is to the right. And I always ask the mother when I see it or when I feel it, I said, where was the back of your baby at the end of your pregnancy? Was he at your left? And then when they say, yeah, it's on our left. And it's always, in the beginning, you think, yeah, is it really so? But when you have a baby who was on the right with their mother, then the preferable side is mostly to the left.
Hmm.
So that's are things that you just pick up or in the anamnesis or just when you're treating. Um,
We learned what
also,
an anamnesis was the other day from Diddy. It's not a word we use
uh,
that often. Now we know what it is.
okay, yeah, it's just, I think it's Latin or something. Yeah,
That's a great word. So LOA, you're looking at a right neck preference more likely. And if it's an
yeah, yeah,
ROA, you're looking at a left neck preference more
yeah.
likely. And that's because of the birth, not the intrauterine lie in the sort of last parts of the pregnancy, or yeah.
It's a combination of the lie when there's a long time that they're being engaged in the pelvic area. Then it can also be the lie, but it's just also the type of birth. But you can also find the rotational patterns from when a baby was stuck, like in the internal rotation, and they use the ventouse vacuum. It's like, I'm
Hmm.
not sure what you're using.
No, yep, both of those words are good.
Yeah, but when they use it and they just pull out, you can feel in the body that they didn't complete their internal rotation, so the rotation is still in the body. You see that when they are just turning, just like parents say that they're just constantly, oh, they're starting rolling, but it's not starting rolling when a baby is 3 weeks old. It's just
Uh-huh.
because there's still something in the body.
That's always interesting, isn't it? When they come in and say, my baby's neck is so strong and they're rolling already. And you actually have to say to them, don't you, look, with some treatment, your baby might stop rolling. Please don't freak out. Like it's okay for your 3 week old to not be rolling.
Yeah, or that you need to say yes, sorry, but it's not meant that the neck is so strong. It's really too strong for now.
Hmm. Hmm. Oh, yes. And what about going off our prearranged questions a little bit? What do you find in babies that have had like a very long labor versus a very fast labor? Do you notice any difference in those babies?
Both have been both children have had a lot of pressure. Um, but what the difference what you see and or measure is more a bit like from the pre and perinatal psychology, I think, because when it has been a long labor, there has been for a long time very much pressure on the baby, and that can be a baby who don't like to be touched, or the baby where the mothers say from, ah, they really don't want to cuddle because I just want to cuddle, but then he's going to be restless, and I just put him down, and then it's fine. And when a baby
Mm,
has been like for a very fast birth, then you will see that the baby just needs to have some pressure, and they really need to get the sensory input because the sensory input from the birth is lacking. And then you see afterwards like a restless baby just because they miss the sensory input in their body.
interesting. Huh. That's very interesting. Because yeah, you do meet so just every now and then I'll meet a baby that doesn't, the parents will put the baby down or on the floor rather than holding them because they're much more happy just being left by themselves. And if
Yeah.
you're interested in perinatal psychology and bonding and everything, like there must be some implications to that, I would imagine.
Yeah, it's really it's good for parents to get bonded, and then you need to start to you can treat it also a bit like when you want to treat that baby is also going to be a bit restless because you're going to touch. So then you need to make cues and say, oh yeah, we know you had so much pressure and you didn't like the much pressure, and just acknowledge the baby and the feelings, and that can help the baby to rebond again and just feel fine and feel nice again by touching.
Mm.
And you can also look if you can give the baby so literally much more space. So working a bit around the midline and the biodynamic zones like zone C or zone D. So to give them a real expansion because they have been so much compressed during birth.
Gotcha. So for those of you who aren't biodynamic practitioners, in the short version of that is to not sort of lean in and have a heavy focus on the baby, but to just sit back and have a very light sort of like interest in what's going on and allowing them lots of space.
Yeah, lots of space and like you can like you see like the body is a bag of fluid and that you give the fluid some space. That's what you can see.
Yeah, let it breathe. What about babies who are OP, posterior babies? What do you notice in those babies?
Yeah, when babies are in osteopathy, occiput posterior, you see that they have sometimes they have like compression points around the zygoma, just
Mm-hmm.
from being around the pubic bone of the mother.
Mm-hmm.
Uh, and also what you see is a very much extension in the whole body because of the tilting around the back. But you see a lot of extension patterns in them.
They're always locked up here, aren't they, because of that brow or face
Yeah,
presentation? And whenever a baby comes in looking like this, like the frowny,
yeah,
face,
yeah.
that's
The
often a
frowny face is
yeah,
sometimes from that, but you can
yeah.
also have that their mother weren't allowed to push at the end face. So you can sometimes see on the skull that this is so like they have a elastic band around their head. Like you also see like the temporals, and that can also be like that the head is like crowning, it's coming out, but it's standing for a long time. So they let the mother wait for a long time over there, and then you
Mm-hmm.
just like you see the perineal ring of the mother in the head of the baby.
Amazing. Yep, gotcha. Interesting. Um,
And
and
then I also start to give you want to, as an osteopath, you always want to work on the directly on the tissue. So you want to give the wings of the sphenoid expansion again, and also the temporals and the frontals. Um, but also just by recognizing, oh, you had there a lot of pressure, so we're gonna give you a bit more space. So yeah, just working with and verbal cues, but also with your hands.
yeah. Um, what about babies that have had oxygen deprivation? I often find those babies are very extended through their body. And what do you find with those babies?
Yeah, babies with lack of oxygen and
Yeah,
who have had a
low
really
Apgars kind of babies, yeah.
yeah, they you find a lot of tension in the whole body, and mainly what you also see is that you low Apgars have often had trouble with breathing. So I often find like the thorax is really compressed,
Yep.
and they didn't have a good first cry to really open the body. So I'm always treating then the diaphragm and have a preference of holding like the ribs very open from the back. So you also have some influence on the central chain.
Mm-hmm.
Yeah, I guess it's the central chain. So you have influence of on the parasympathetics also, so they can just relax for their whole body because they're really tight. Yeah, so it's mainly the opening up because they're really stuck in the
Yep.
midline.
Yep. Yep. Uh, back to the actual questions that I sent you
Yeah,
through.
that's fine.
Um, so you take notice of a baby's facial expressions and body language to understand more about their positioning and well-being. How do you read a baby's face? What cues do you look for in your assessment?
Yeah. like I did some, I got it from Carlton Terry. He's also like for the peri and prenatal psychology.
Alton Terry, is it?
Carlton Terry, yeah. But I did his online course last year or 2 years ago, and you're just going to look how is the face showing you how the birth have been. So, for example, like the frowning we had where we talked already about, but you can also in most persons you can see what their lie side was, and you can see it on the eyebrows, because
Hmm.
mostly the left side is there where the eyebrow is a bit lower, because that's the side where the baby needs to get over the promontorium of the sacrum. And there you see that there's more pressure. And
Mm-hmm.
then you see like the brow is a bit lower. And you can
Hmm.
also see like that eye will be a bit more to the midline, depending on how much stress there was during birth. So that's one of the things. So then you can really see where is a lot of more pressure been, mostly on the sphenoid bone or the orbit.
Mm-hmm.
And you can also, in very young babies, you can see it very much, or you can see, well, what did the baby do when they need to turn? So when they have been doubting uh, for a long time, for example, so should we turn to occiput posterior or should we just make an occiput anterior birth? Then you sometimes see the zigzagging and you see that the nose is kind of bit of not straight. And then
Mm-hmm.
you can exactly point out on a picture, you can point it out. So there was pressure and there was pressure, and you can do it with arrows. Or
Right.
sometimes you see like babies who've had the hand, because sometimes you see, oh, the jaw is very asymmetrical when they open their mouth. And then sometimes I mentioned it, and sometimes then parents suddenly say, oh yeah, they were born with the hand beside their jaw. And then I say, oh yeah, okay, that's I can count it. So I see it back in the face. So it's real nice to see, oh yeah, that was the lie side, and then you know a bit more where was the pressure.
Mm-hmm. Mm-hmm. Gotcha. So just a real, like all the visual cues of asymmetry that you kind of put together to
Yeah.
think about their birth process and how those things have occurred. Gotcha.
But
Alrighty.
sometimes you also see that a baby is signing themselves where they had a lot of pressure during birth. It's often it's a sign what's often misdiagnosed, I think. It's like the baby who is rubbing in their eyes. Just and then sometimes parents say, "Oh, they're tired," but then you said, "Yeah, but did they sleep well, or when did they sleep?" And then they said, "Oh no, actually, they're just awake." So when a baby then constantly is rubbing their eyes, sometimes like it's baby body language, and the baby says, "But there's where I had a lot of pressure during birth."
Mm-hmm. That's interesting. Yeah, right. Because I've often seen babies like tug at an ear or something, and I just always thought it was maybe a little bit congested through their ear, but that might be a compression.
Can also, yeah, it can be a compression point, or yeah, it can also be like the concussion. It's not just always
Yeah.
exactly. You
Yeah,
can just
right.
have an indication.
Mm-hmm. Mm-hmm.
That can, for me, that can be a sign to just explore that region and just look for if I find something there.
Yeah, yeah. Okay. Pre and perinatal psychology play a significant role in your practice. How do you see early birth experiences shaping a child's behavior and development?
Yeah, I think it's always has a impact the way you've been born, and I did uh, a lot of courses around that topic from different teachers. But one of the things like babies or children who have been born by a elective sex show, you will see that that will mostly be children who always um, want to have the strength. So I will do this by myself. They want to choose everything for themselves because they haven't got the chance to choose their own birth. So they're kind of compensating and always looking for their own boundaries, and they will exceed others' boundaries because I couldn't have my own birth, so now I want to just do what I want.
Thing.
So that's the thing what shapes like a bit of the character.
Hmm.
And you also see like babies with vacuum or forceps birth or the non-elective sectios. It's like that are can be people who have always trouble to finish things because they couldn't finish their own birth, so they will always start to stuck to something.
Right.
So that's just, yeah, something what you sometimes just can give to parents because they have problems with dealing with their child, and then sometimes you can just say, oh, but it can be related to birth, because you can't say directly it is, but it can be related by birth that your child always wants to do things on her way or his way. And one of the cues I give to parents then is sometimes for, so just tell your child her or his story of his birth, um, and recognize the feelings that you had and that the baby might have or the child might have, so they can heal that for a part.
Yeah, right. Oh, okay. So are there other types of presentations that you see that you relate to different personality traits in children?
I think there are a bit more, but I'm not quite sure that I really see it always. But there are, yeah, I think there's also coming a bit more uh, evidence slowly. I think it took a long time for the pre and perinatal psychology to get a bit their way in medical science. So I'm still developing that myself also a bit, how can I incorporate it, because I'm always also very upfront to keep osteopathy and not doing all parts. So I
Hmm.
really want to integrate it and not only work on that part.
Hmm. Hmm. I've really only heard about um, infant mental health over the last few years. It seems to suddenly be recognized that infants have, a their own sort of like, I suppose, personalities, but I guess more than that, that there's so much that influences their whole life really in those early years of um, not just sort of being treated poorly, but all sorts of subtle influences on their personalities and their lives. And I suppose it makes sense that birth, it's such a hugely significant event in a baby's life. It makes sense that it would have impact on their mental health. I'm just thinking to some of the children that I've seen, and I talked about this with Diddy a little bit as well, that uh, the children that we see that have been born with quite low APGARs that really feel deeply traumatized through their bodies, and the kind of progression that creates within that person as they grow up, having had a really traumatic birth. Is there much you can talk to me about those babies?
Yeah, I think we have all, yeah, it's just what you say. There's a there's a slow wave coming and more recognition. Um, One of the things, mainly with premature born children, you see that they have their lifelong problems with all the sensory input in their body. So I think that's also a part which is slowly recognized, that they know that premature born babies, uh, that they are sometimes a bit slower in processing, but like they correct the age still too. 2 years. But it can be people who have problems for their whole life, also their adult life. So like they can't process fast enough. They can have for a very long time problems with their lungs. Uh, so it's very important that they're going to do more research on that topic also, because yeah, sometimes there are also some difference in when to treat premature babies from when on, and yeah, what is quality of life and what is not quality of life. But I think that they're still not completely uh, know what's all the impact from what they do to keep babies alive, but also what do the premature birth. Um,
Mm. Actually, that was one of the other things I was interested in asking you about is part of your practice is treating kids with disabilities and also kids with neurodiversity. Are they two areas that you're also interested in?
Um, yeah, I really have also a deep love for children who are just like they're just different,
Mm.
but they're children. Um, and yeah, you just see that one of the yeah beautiful parts is that I see that parents are struggling with their children, and that you can just play a role also in helping the parents understand their children better. And when treating the neurodiverse children, I always have also a look on the primary reflexes, because sometimes children get a diagnosis of ADHD or ADD, but sometimes there are just a lot of primary reflexes which are not integrated enough. So always check them for that. Uh, yeah, I always have I think parents of children who have a disability or a neurodevelopmental problem, or they're almost always very caring for their children, and they will do everything for their children. And that's very beautiful, but you see also like the parents are going to burnout um, sometimes. And I've myself, I have two very high intelligence children. So especially with the oldest one, we struggled a lot, and just uh, to get the education on the right level. And now they're bigger and it's easier. But yeah, I also feel familiar with a lot of parents who are struggling with the education and with other people, because you know how difficult it can be to get for your child what you want, and you bring your child somewhere, or you put your child on a school and you think that's the right school, and school has their expertise and school is going to do, and then you came a bit disappointed because that teacher is not going to do it because they don't believe you, or that kind of stuff. So, and in my practice, I really connect to the children, and yeah, keep it on a personal level, and also yeah, just safe, because you're a beautiful child and you can yeah, reach what you want, or you can just have your desires. And I think that's really beautiful, because most of those children are also very open and not yeah, they don't have any back door, where they're just open and just honest to you, and that's nice.
Yeah, yeah, yeah. Oh, yeah, that's fantastic. Um, Thank you. Uh, the next question I have for you is about breastfeeding issues. Um, we've talked a little bit in Osteo Kids Academy about the different types of tools people use to assess tongue ties and breastfeeding, and I'd be really curious to know what assessments you use, and if there's any particular approaches or techniques that you find really useful for breastfeeding issues and tongue tie.
Yeah. Yeah, I really like to work with the small newborn babies, because then you get them really fast on your table. And I mainly, in the beginning, I was also a bit reluctant with just say, oh, at 6 weeks, it's enough. it's early enough. But when treating a lot of babies with breastfeeding issues, I just find something, the earlier you get, the faster you get it better. Um, so I just do my normal assessment and just like always starting at the feet and do like some primary movement for flexion extension, side bending, rotation. But I then afterwards, when I'm just getting higher up, because I'm always building up from below to the upper body, because when you directly dive into the mouth, they don't like it, and then your whole examination is on the floor. Um, but for that, I especially focus on the clavicles, because I often find like a baby is a bit this way, and then I also tell parents, so now I'm giving your baby a bit of neck, and then you will get easier to clean up also clean the neck. And a lot of interest in the anterior fascia, like hyoid, but also sternum and diaphragm, because
Mm-hmm.
I think in breastfeeding, it's not only like sucking and swallowing, but the breathing is also very important, because when they can't breathe, they will constantly leave the nipple and they get a lot of air inside.
Mm-hmm.
Uh, but one of the things I mostly do, and what not every osteopath does here in the region, is just treating intraoral.
Yep.
And when treating intraoral, just taking the pterygoids, lateralis, medialis, the bottom of the mouth,
Mm-hmm.
um, because that's very important to just get there more, more mobility. And I'm very lucky, because we have here in the neighborhood, we have like a multidisciplinary group with a pediatric dentist, which is specialized in lasering the tongue tie and lip ties. Um, they have just a special day. They are always on Wednesday mornings. They are there, combined with two IBCLC lactation specialists. So they have two rooms. Parents come with their baby, and like the lactation specialist is looking in the mouth, is looking for the tongue tie. How is the tongue tie? But most important, because a lot of people don't have much knowledge about tongue tie. They think there's only a tongue tie when you see it, and when the tongue is really to the tight, and you see the tie. But
Mm-hmm.
there can also be a lot with the like hidden tongue ties. So there, and they also looking for the cues, like if there are blisters around the
Mm-hmm.
lips. So then the lactation specialist just is looking, feeling, how is the sucking, and then she also already start to teach to the parents how they can do some exercises which need to be done after the lasering. And then the dentist comes, and she also again just screens for all the signs and if it's necessary. So I'm really delighted that I'm very sure that they will look good, and when it's not necessary, they won't do it.
Yep.
Because
Okay.
you also have a lot of clinics who said, yeah, okay, you say it's a tongue tie, we will laser it. Um, they also always get like some exercises which they need to do afterwards. The lactation specialists are guiding them after lasering. They can directly go to the breasts or get some bottle, and lactation specialists also give some tips and tricks how they can do it better.
Mm-hmm.
Uh, and we have kind of like when they have type 1 or 2, according to the Hazelbaker score, they will laser directly always, and give some advice to treat osteopathically afterwards. And when there's a type 3, 4, they mostly say, oh, just go to the osteopath and look how good you can get some more mobility. So then I will especially do also the bottom of the mouth from exterior, but also intraosseous strains in the mandible. Because of the extreme flexion, you will see sometimes that there's some compression.
Mhm.
So, and then I treat, and then they just contact again. Um, so it's really nice to work together and have short lines. Uh,
Mhm.
and that's also why I'm also teaching with them in in very short time. And we also have in the multidisciplinary group, but we're also exploring that a bit more. We started it during Corona. We have an OMFT therapist, so an oromyofunctional therapist for the older children. So when the dentist is lasering, um, when children are 4 or 5, then they go to the OMFT therapist for more exercises because their tongue habits and mouth habits are already in for 4 years, so they need to have more exercise. And there's also pediatric dietists in there because it's mainly because the dentist saw a lot of children with like caries, and she wants to prevent that a bit more. And
Yep.
as a group, we're still looking for like a pre-verbal speech therapist, but there are not so much here in the region. And one of the problems is that it must be also someone who is behind the tongue tie work, because yeah, I think we saw it also a bit in the community, but you also see it like everywhere on the internet that there's also a lot of controversy about tongue tie, because they say, yeah, you see it so much, and is it definitely necessary? um, and for me, it's just that I see that it's very it's necessary when it's really necessary. Just for example, when there's a lot of problems with feeding, and yeah, it's not something you do because you think, yeah, I can do it. It's not like a aesthetical operation or something. um, but it's also something where I said, when you don't know, you don't see it.
Yeah. Yeah. It is a tough one, isn't it? Because even if a baby scores really poorly, sometimes they could get a tongue tie release and it'll work beautifully, and another time it won't work that well.
Yeah,
And even with manual therapy, sometimes there's still a lot of issues with that baby feeding. I still really struggle sometimes with some of the babies I see to get them feeding well. And yeah, it's just a bit unpredictable. It's not like a lot of the other things we see. Like if a baby comes to see me with a neck rotation preference, I'm very confident that I can, sort it out.
yeah,
And feeding is not like that for me. Like a child that is really struggling to feed can be a real challenge, I think, for
yeah.
to sort out. Yeah. And
Yeah,
yeah.
yeah, I think that's one of the most difficult parts, I guess, from our work, is like feeding issues. Reflux is not so easy because there are a lot of components who have influence on it, and we don't have a lot of influence. And it's also like what you said, the preference of rotation. We can have a lot of influence on that, so that the rotation is free.
Hmm.
But sometimes you can have also with that you think, that was all free. Why isn't getting it better? But then I
Hmm.
sometimes think you need to realize, like, they're for 3/4 of an hour on your table, and the other part of the day they're just by parents. And when parents are not attentive enough to train their baby to the good side, yeah, you can't have that much influence. And feeding issues are always difficult. Yesterday I just was at the dentist to have a look how it practically went, and there was also a baby which I treated, I think, 2 or 3 times, and mother was very sore, had very sore nipples. um, because he said, yeah, it's like a little piranha. He's just biting on my nipples. And there was really a lot of tension, but I thought, yeah, the tension is better. And every time he thought, yeah, it's a bit better. And also got some tips from the lactation specialist. But then she said, no, it's just so painful. So she said, yeah, should we have a look by the dentist? So I said, yeah, I think it will be a good opportunity to have a look with her. So they were there yesterday. And then they said, just the father was also with them and said, yeah. They say, yeah, it's definitely an indication. And then the father, the mother said to the father, yeah, do you really want to do it? And then he said, yeah, but I'm hesitating a bit because we're getting a little bit more comfortable with everything. And then maybe when we laser, then we just disturb everything and we're going to struggle again for 6 weeks. And then, yeah, we just need to level a bit with the parents because the mother wanted it definitely, but she also want like the encouragement of the father. And then we just said, because like the tongue was already uh, having a good mobility for a part, except like the deep tongue tie, but he followed well when you put your finger in the mouth, and he sucked also really hard.
Yep.
So then we also said, like, the baby is already having a good tongue mobility, and it's trained because the baby was also growing, so there were no concerns of not growing. And we said, yeah, when they do it, the baby needs to adjust a bit to a new sucking pattern. But it's not like when you have a tongue tie, which is really tight to the bottom, then the tongue doesn't have a lot of exercise for making good movements. And your baby has already that. So there's like a motor pattern in his system, but he just needs to find a way which is the most easiest way to drink. So then they did the lasering. So Daddy was also aboard, and yeah, then she put him on the breast, and she said, "Oh, finally, I don't have any pain. It's so much different."
Mm.
And so yeah. So it's always they start to have trouble, and especially also when children already have problems with gaining weight, you don't know, yeah, it's a thin line. You don't know if you're going to see direct better, that's going direct better.
Yeah.
So
Yeah. Yes, it's definitely an area that I would like to get better at. And particularly, I mean, we can assess a baby's tongue tie and refer them to the appropriate provider. I just wish there was a bit more of a consistent understanding for myself about the babies that I send, knowing which ones are going to benefit and also which ones are going to, because this happens too sometimes, doesn't it? Where they're not feeding brilliantly, but they're getting by, and then they have the tie release and they're significantly worse for a while. And it's like they have to relearn how to suck, and it's incredibly stressful for everyone. So
yeah,
yeah, it's could be a really tough road. I wish there was more clear guidance. I probably just need to do a bit more study on it. But it sounds like you've got a great team with you there that helps you with all those things that, as an osteopath, our scope of practice and having lactation consultants around and dentists and orofacial biologists around as well that
uh,
can just assist with those decisions and support the family.
yeah, yeah, that's really nice because you can form like a network around the family. um and but I must say, I just trust those two lactation specialists the most.
Mm.
And there are a couple others in the region, but when
Mhm.
people come and there are feeding issues, and they said, yeah, but the lactation specialist was there and it was all fine. But I'm always then looking extra careful myself because I'm not sure, because I see they miss sometimes like big ties, or that I think, yeah, it's not good. So then I always say, yeah, just go to the dentist and and just
Yep.
let them see, because yeah, it's really difficult, and that makes it also difficult to really to get to know what's best to do first. And I'm
Mm,
really reluctant that we have like the 3-4 type tongue tie, that we say are just, we first try osteopathy the most, and then when it doesn't work out, then we're also going to show what the later will do. And yeah, also
mm,
there are exercises. The exercises need to be done by the parents. That's also
mhm,
what not so easy.
mm,
But they mostly try to do it, and like it's 6 times a day what they recommend.
mm, mhm.
And sometimes parents say, yeah, but it doesn't take 6 times a day as much. And then I always said, yeah, but there's a kind of marge in it. So like when you do it 4 times, it will always also be good. And when there are babies coming at my place, then I say, oh, I will just treat in the mouth. So I will also do the exercises for you. That's just that
Yep.
you don't have it to do
Yep.
again today a bit more. So
Um, Final question. What is your all-time most favorite thing to treat in babies?
in babies, yeah, I definitely think it's the breastfeeding issues,
Yeah.
because you can, yeah, because you can have just such a quick result. So that's when you treat, and you treat intraoral, and you get just that the coordination is a bit better. And then it's always nice to say to the mother, because they are a bit of restless. So yeah, just put your baby on the breast, and that they say, ah, it just feels different. So you have such a direct result of what you're doing. That's what I really like. And I also
When, yeah.
like to treat not specific issues, but I also find it nice to treat twins. It's always nice to see like the difference.
Yeah.
And you also can see some difference in the kind of birth they had, or the kind of pregnancy they had. Like had some twins with had the twin to twin transfusion syndrome, they uh, which they treated when they were 18 weeks old. They just yeah, broke the connection, and then they were born prematurely. But just that you see, that you feel like the one baby has got it all and one not so much. But I also had a twin who had not exactly the same, but one was very small and one was really big, and one had been lying on the upper side of the mother, just below the diaphragm. And he was just like, he was really grown like a twig already in the mother's belly, and it took so much time to get him really straight. So
Mm,
then after treatment he was okay, and then suddenly he went again, so we have treated him a lot. But
mhm.
it's nice
That
then to see
happens.
the difference. Yeah.
Yeah. I often, once we get everybody straight at our practice, when we're discharging people, we often say to them, just in case this happens, it doesn't always happen, but your baby might go through a big growth spurt in a couple of months, and slowly you might just see them sitting in the high chair and they'll just start to tilt off a little bit again, or just that those little preference will come back. And it's like we've given them all this space, and they take it all up, and then they sort of hit the end and start to tilt off again. And so, yeah, some babies, particularly the really jammed up ones, do sometimes need a check in a few months, don't they? Just to make sure they're on the straight and narrow.
Yeah, yeah, yeah. That's
Yeah.
always difficult, I think, to motivate parents to, or come back when they think it's okay, or but it's not a must for me. I always let it very open to parents. So I always say, okay, it's three. I think I'm ready now to let you go, but when there's
Mhm.
something, you can call me. And I always said, yeah, some parents choose to come regularly, and so I leave it very open. But sometimes I think it could be better that we're just more, but yeah, when you have a full agenda, it's not so, it's not a necessity for yourself also.
Yeah. Yeah, that's an interesting one, isn't it? There's always that balance of trying to understand what's best for the family and what's convenient for everybody. I suppose I always just think um, that I have to advocate for that child first and foremost. And if I think they need treatment, I just say it and then, you know, see what happens after that.
Yeah.
Yeah, yeah. Can I ask just quickly,
Yeah.
when you're doing intraoral work, do you treat the baby like this, or do you treat them like upright? How do you actually position a baby?
I mostly position the baby just on my treatment table,
Hmm? So it's
and then
just
I,
supine like this?
yeah, just supine,
Yep.
and just then sometimes I hold my hand like at the condyles, because I then can also treat like intraoral and with the condyles together, also give there a release.
Huh?
But it depends. I'm really not so fan of getting the baby really stuck. So I'm really mostly working one-handed and just a small support with my upper hand.
Hmm?
But I mostly do it that way, because when in my arms, then for my feeling, they're a lot more flexible and a lot difficult that you don't get them to choke on your pinky. But I mostly just lay them down.
Mhm.
Um, and yeah, sometimes work with two hands, but yeah, not
Yep.
so tight, because I think they also need to have their own, to find their own pivot sometimes.
Yep. 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 Yeah. Definitely, I find having the baby like this it's much easier to do like palette kind of
Yeah.
work. But I've been doing lots of intraoral work with the baby upright like this. So I'm looking at the mirror and I can do lots of work this way.
Oh,
Um,
okay.
which I learnt off a speech pathologist here in Australia. And they tend to put up with me doing a lot more if I've got them upright, looking at themselves in the mirror.
Oh,
It's definitely it's you can't really do much palette work in that position though. That's a tricky one. So having them
yeah.
sort of, on a pillow or on the,
Depends also a bit on the age of the child, I think. Because
and
when
that's
I have
right,
a lot
yes.
of, yeah, sometimes 2 days, 3 days, 4 days, 5 days, 6 days, or
Yep.
7 days old, yeah, then you
You
don't
can't really. They're a
get
bit wobbly,
around
aren't
of.
they? Good point. Yeah, you don't want them lolling all around the place while you're trying to work on them. That's
Yeah,
true. Oh, thank you so much. Well,
yeah,
I appreciate catching up with you so much, Cindy. It's been a really interesting conversation and such a broad range of topics. Thanks so much for giving us your time. I really
yeah,
appreciate
it
it.
was really nice.
All right. Well, we'll leave it there. Thanks again, and
Yeah,
yeah, much appreciated.
yeah, it's nice. And if you want to come back and talk about some other topics, you're welcome.
Sounds like
It's
a
nice.
plan.
Yeah.
All right.
Okay.
Thanks,
Hey,
Cindy.
have a nice day.
Thank you.
Bye.